So what made you become a doctor, Dr. Romero?
There was a number of factors, Omar. Um, I think one of the most, this is a little bit of a long story, but I'll be as brief as possible.
Okay.
First of all, I was born in Colombia,
Okay.
South America, and that made a difference, especially in the beginnings of my career. And why I became a doctor, I think, was influenced by several factors. One that I consider very important, and I have talked about this and analyzed this issue in psychoanalysis, my personal psychoanalysis. When I was about 3.5 years old, I have a sister who was 1 year younger than me. Both of us contracted whooping cough. That's pertussis produced. And at the time, there was no antibiotics or vaccinations or treatment or anything. So we were in Colombia, and our pediatrician asked or recommended my mother to have the treatments of the times, and nothing worked. So my mother went all over the place, desperate because we were very sick. At that time, this kind of illness killed children. And it happened that the pediatrician, that is, asked her to go to a town with a different climate. In tropical country, the temperature changes according to the height above sea level. And what he wanted to do was to send us from the capital city, Bogota, which is a city with a rather cool climate, cool or cold, down to a city 2 hours away from Bogota for a change of climate. He didn't know why at that time he recommended that, because today we know that the immune system improves more effectively when the temperature goes warmer. So, but he didn't know that. He just knew that that might be a way to improve our health. So my poor mother went along with the two of us to this little town, and I saw her suffering and, carrying us, and we were coughing horribly. And when she arrived in that town, we didn't have much money, so that was a big sacrifice. So we were poor, very poor. So when we went to the little town and we were coughing so badly, nobody wanted to take us in their hotels. So my poor mother had to spend the day there, taking advantage of the climate, and then travel back that night to the city, to Bogota. And as a result of that, we think I got better and I survived. But next day, my little sister died. So I am the survivor. And watching my mother suffering and going to this doctor for help, I remember, of make me admire the power of a doctor. And at the same time, make me feel proudly the guilt of the survivor sibling. And I think that that's when I had the first seed of my medical inclinations placed in my mind. Second to that, it was that I am the oldest of 4 brothers. I mean 5 children, but my sister died, plus 3 brothers. And because we were poor, my 2 parents had to work all the time. And I was left in charge in the house, in charge of my brothers, and responsible for them, for their care and everything else. So my drive to care for other people was stimulated further because of that. You have another question there, asking what made me stay as a doctor.
Yeah.
When I started going to medical school, my mother got sick, And she got sick for another infection, tuberculosis, that got to her kidneys. There were no antibiotics either at that time. This is in the 1940s. I may correct that a little bit because at the time penicillin was coming into the market, and a second antibiotic that was effective for tuberculosis infections, which was streptomycin, was coming too. So she had a chance to survive, but she couldn't avoid having a nephrectomy, taking the kidneys, one of the kidneys off, and she was nephrectomized. And yet the doctors told us that my mother might not survive because her heart was being affected by the loss of a kidney. That's the way they thought at that time. So that really hit me again, that I had to pursue my career as a doctor. Never mind all the needs of the Colombian people, medical needs, and poor people dying from these and those illnesses that really got to me. So that stimulated my desire to become a doctor further and to stay in medicine.
Okay. So what did you choose as your specialty, Dr. Romero?
Again, my mother, she suffered from heart failure, and she has something else in the conductivity of her heart. And my professor of cardiology called me and said, Hernando, you have to study cardiology. And I said, well, yes, I would, any specialty or something. And he showed me my mother's electrocardiogram, but he also told me we have very little to do with your mother's heart. It's not much the tools to work with. So although I had thought of cardiology, I got disillusioned from that. Then I went in my training in medical school, and I went into the surgical clinics. But I became a little disillusioned to see that once you do an operation, it's the same for all cases. So it was, in my opinion, kind of too manual, too mechanic. And then I thought, maybe psychiatry is the only specialty in which you can put a lot of yourself, your own initiative, and your own invention capacity, and use your own personal resources to help people. Besides, at the time, psychiatry was like more magical, because there was a lot of talk about psychoanalysis and all these mysterious things that psychiatrists did, through psychoanalysis and psychotherapies. At the time, psychiatry had very little tools to work with. The medications that we had available to help people were 1, 2, or 3, the old-fashioned ones, and that was all. We also had electroshock treatment and insulin coma treatments, and that was about our armamentarium. So I thought I have to use my mind, to help people, and that fed into my determination to become a psychiatrist.
Where did you attend medical school?
In Bogota, Colombia. I did my studies at the National University School of Medicine.
And what year did you graduate?
In 1958.
Do you remember the tuition of your medical school?
I went through scholarships. I was very poor. But most students paid like $120 for tuition per year, which was a lot of money for us. But because I was a good student and I worked hard, they gave us a scholarship and I paid $5 a year.
Do you think that any of your friends who are affected by the med school costs and where or how they practice medicine at first?
Yes, in Colombia, many people had to do something else because the cost of going to medical school was tremendous and very, very expensive. Books and room and board and all that was very, very, very expensive at our economic level that time in that country.
And how do you think med school costs influence the choices of young doctors today in America after they graduate?
I think that in this country things have gotten better. Among other reasons because of the loan systems and the scholarships. I belong to the Worcester's Medical Society Scholarship Fund Committee.
Okay.
So I have had the opportunity to read all the stories that the applicants give to us and how they, but in general, people have more resources to become a doctor even when they don't have much money. However, this is not to say that still the cost is tremendously high. You know, to become a doctor costs like $300,000 or thereabout, not counting it all. And people get into debt and they have to struggle to survive and make it.
Okay. Well, could you describe a typical day of practice when you first started here in Worcester?
When I first started in Worcester, I worked in a hospital only. Let's say the Worcester State Hospital. I couldn't have an office initially because I was not licensed to practice at a private level.
Right.
I have to work under the license that the hospital was giving me. So I worked full-time in the hospital. I lived in the hospital grounds. I already was married and I had 3 children, small children. So fortunately, we could live in grounds, and that facilitated that I spend the whole day in the hospital doing my job. So I left home at 8 o'clock in the morning and came back around 6 o'clock and have some time to spend with my children. However, I remember it was very hard those first years because, one, I didn't speak English. I still don't speak it as well, but but in those days I spoke very little, and that took me more time to do my job, to communicate with the patients, to write the histories, and all that, than if I had spoken English well. In addition, I was preparing for my boards in medicine here in Massachusetts, towards getting my license to practice in private practice under my own license, and also because I wanted to have my boards in psychiatry and neurology, and so I could be fully licensed and qualified. So that took a lot of time from my family. I had to come home, be with my family a little bit, and then study until 1, 2 o'clock in the morning and get up to work next morning. So it was kind of rough. And besides, your family resents that you spend so much time with the books and with the patients and with your colleagues and meetings and all that, and very little time with them. Today, my children still tell me that.
And how about during the rest of your career? What do you think it was like for your family to have a physician in the household? I mean, did you get to spend more time with them later on?
Well, still, I had to work to support the college tuition for my 3 children, and I also paid for my wife's going to college here. Right. So there were 4 people that were whose tuitions were being paid by the products of my work, and that kept me away from them, which I don't regret. except that I didn't have time to be with them as much as I wanted. When I became comfortable and I made a better income, my children were already grown up. I didn't have much time to spend with them. So that was a price that we have to pay for me being in medical practice.
Did you ever make house calls during your career in medicine?
Here in the States, in Colombia, I did a lot
Okay.
because there was no other ways to do it.
Yeah.
Here, I did less, but still, I did house calls. I was one of the founders of, for instance, a mental health clinic at the Graybrook Valley. As a branch of the Worcester State Hospital, we opened clinics different parts of the city in the community. And one of them was at the Graybrook Valley. So when we had our scheduled hours there, we went there to their homes because we had a clinic in the project, the house project. And we went to see the patients in their own places because many of them wouldn't like to come to the clinic and be seen coming to the mental health clinic, you know. And I had to do that. I also visited many elderly patients who just couldn't come or go anywhere for their examinations.
And how else would you communicate with your patients throughout the course of your career, aside from office visits and house calls?
Mostly, we did home visits and some telephone calls. At the beginning, many people didn't have telephones, and it was very difficult. So we have to go in person or send messages with the nurses that work with me, or we just didn't communicate. As you know, communications have improved 1,000%. Lately, everybody has a telephone. So today is regular thing to talk to them over the telephone.
As well as a computer, and do you use a computer?
Email, yes. We do computer, email work, but mostly it's telephone.
Okay. Now, could you describe your rounds at the hospital a little more? I mean, would you like to elaborate on those and how they've changed?
We had different modalities of rounds. Of course, we had the classical meeting with all members of the staff and with a clinical director presiding and running the meeting, and we sat all psychiatrists in the staff around a big table, and at the head of the table was the clinical director, and around that big table were the paramedical disciplines like social workers, nurses, psychologists, and the clinical director asked one of us to present a new admission, and we read our materials. He used to, at that time we had a very, very strict director who had been a colonel in the army and was using those means to make us comply and do presentations that were very much detailed. So our write-ups were very complete, very thorough. And we had the time to discuss our patients and to reach conclusions, and he made the final decisions about this, about the treatment of the patients after we made our comments. So that was one modality of staff conference and rounds. Twice a week we did that in the hospital. We also had more academic discussions, and one of us presented subjects that were in fashion and presented research papers and so on to the rest of the staff. and then a discussion opened. That happened once or twice a month. So that was the type of rounds that we have in those hospitals.
Who were your patients throughout your practice? I mean, what type of people were they?
It has changed, of course. Here in the States, when I started my career, it was the hospital, the state hospital patients and the VA hospital patients, and those were people who had to be treated in the state psychiatric system because they don't have insurance to be admitted to private hospitals, or because they were too sick to be admitted in private hospitals. At the time, patients that were too ill, too much out of control, too regressed, too agitated or violent, were sent to the state hospitals, where we had more means to control those people. So those were my patients at the beginning. Then when I started going into private hospitals, my socioeconomical level of the patients went up, and then I had the chance to treat people who were not as sick, who were more sophisticated, more educated, and capable to benefit from techniques like psychotherapies. So my type of patient changed. It's also to be reminded that the type of psychiatric patient changes when the patient is committed to a hospital than when the patient volunteers to come for treatment.
Of course, yeah.
So patients that come here must be people that are not as ill, or if they are, they know how to control themselves because they are more, as I said, more educated or sophisticated. So they can sit down in my office here without taking the risk of attacking me or destroying the place, things like that. So that changes, actually, the type of patient.
All right. Well, I'm going to ask you about the science of your practice now. First off, could you tell me what the most typical illnesses were that you dealt with early on?
At the time, at the beginnings of my career, schizophrenia was the most typical type of patient. Patients with diagnosis of schizophrenia. As you probably know, Omar, schizophrenic patients have all kinds of thought disorders, especially delusions, hallucinations, and bizarre behaviors. And so that was the type of patient that we were treating, and at the time when I was in training. The other type of patient that I had was the patient that came to the outpatient, and they suffer from what we call at the time anxiety disorders. But in the first group, I must add, there was some people who suffer from manic depressive illness, or that was the name at the time. Then it was changed to manic depressive disorder, and then to bipolar disorder today. That was the other type of patient that, or illness that we used to treat frequently. And the third group was the group of the anxiety disorders, which included post-traumatic stress disorders, phobias, obsessive-compulsive neurosis, all those type of illnesses there. The terminology has changed, so it's different, a little different today, or a lot, I should say. So that was the type of illnesses that we dealt with mostly in psychiatry at the time.
And those have remained the same to now, and you still see all those three?
Generally speaking, yes. But today have a little more sophistication. Yeah.
What was the greatest challenge for you to treat when you started practicing?
The greatest challenge was to use my psychotherapeutic training to help people get better. Because we didn't have the medications that we have today, we had to dig with our fingers, so to speak, then to help a patient. Then we have to deal with the schizophrenic patients, with patients that were psychotic, that were very, very sick, with only 3 instruments: 1 shock treatment and 2 insulin comas, and 3 psychotherapy. So the patients that were not able to take any of the first 2 type of treatments, we have to do it all with psychotherapy, with isolation rooms, with activities in groups, individual psychotherapy, group psychotherapy, only psychotherapies. But of course it took a long time, and sometimes it was impossible to deal with the type of patient that we had in psychiatry at the time. Yeah. It was the major challenge to do the treatment of the patients without the medicines that we have today.
What have you seen as the most important, or one of the most important breakthroughs in disease treatment throughout the course of your practice?
Oh, there are quite a few. But the most important, grossly speaking, is that we learn a lot more of what the brain is all about, the brain itself. Yeah. The discovery of the so-called neurotransmitters in the brain was a tremendous breakthrough. By the way, remember that one of the 3 most important neurotransmitters was discovered here in the Worcester Biological Foundation. That was serotonin. That was discovered here. I don't know at this moment how dopamine and norepinephrine were discovered. But discovering these 3 neurotransmitters are learning a little bit about how they function and how they participate in the cause of the symptoms like hallucinations, delusions, hyperactivities, agitation, gave us a break to produce medications that counter-arrest, the pathological action of these neurotransmitters. So today we have the famous antipsychotics or the antidepressants or the anxiolytic agents. Thanks to that. That was a major breakthrough. Psychiatry completely changed ever since. And that happened between, say, electroshock treatment was invented in 1937. And beginning in 1950, lithium, the antidepressants, the antipsychotics, all the new medicines were discovered in the second half of the past century. It was a tremendous amount of progress that was made. So that was one, I would say, of the most powerful breakthroughs that we have had in psychiatry.
Could you briefly talk about attitudes towards smoking and cancer throughout your career and how they've changed?
It has changed a lot. In fact, not all, but I would say at least half of the doctors at the time used to smoke. And it was kind of, gave you a certain status in society when you smoke, say, lit up a cigarette in front of your patients. And people, everybody who wanted to be fancy and so on, carried their own cigarette boxes and tremendous lighters and things like to show off, and to smoke in public and so on. So it was something that initially you kind of admire, It was kind of impressive type of thing to do. Until we began to realize that cigarette smoking produced illnesses, and that it was a deterrent for your good health. And then cigarette smoking began to be thought of as something that was damaging for the smoker and for the non-smoker as well, and consequently smoking began to be eliminated from the clinical settings, progressively. And today, when you see people who smoke, you kind of look down at the person. so,
Right.
so it's a kind of change in attitude, sort of, yeah.
What is something that doctors seem to take for granted now in terms of technology that you didn't have at some point in your career? In psychiatry or just in medicine in general?
Throughout my career, of course, in psychiatry, we haven't had the capacity of other specialties to go to a microscope or to any kind of lab testing and find out this is pneumococcus such and such, or this is gonococcus, or this is the levels of blood sugar are elevated and the insulin levels are diminished, or things like that. We don't have in psychiatry, and we really starve for testing that are more capable to determine specifically what's wrong with the patient's minds and brains.
Yeah.
So we have lacked that type of objectivity to make our diagnosis and treatments all our lives. Fortunately, I would say we are beginning to learn techniques, to watch the behavior and the changes of the brain when things are happening with the PET, the SPECT, all techniques that are so far still in the beginnings. But now we can see how certain areas of the brain change when a person is having a hallucination,
Right.
And we can see something of that happening, and right in color and everything. So that's beginning to open up a window for us, yes.
Yeah, that must help a lot. Would you like to talk about one important invention that you've seen as you practice psychiatry? Or just describe it?
For the practice of psychiatry, I think that one of the inventions that have contributed a lot to our progress is the computer. And of course the computer applied to the research, and in the brain work, and applied to our research, to our daily work at the office. Is right now I am involved in a project, national project, and they have sent us a computer to register our daily activity, and we managed to send it to the headquarters in Washington, D.C., where they are collecting the information from all over the country, from psychiatrists from all over the country. So that is a tremendous breakthrough. But never mind that, there is also all the technological progress that has been made thanks to the computer. And the microchip is being sensational to make possible so many things that we do today. MRIs, the CAT. The CAT scan was very impressive. I think it came in the 1970s. A professor in Tufts, a physicist, was the one who applied the technology to computerize all the pictures in a round circle into one single picture. That's why they call it computerized axial tomography. Very, very interesting. And from then on, the other techniques that have come afterwards, sensational. So,
Okay. What would you like to see invented in psychiatry or generally in medicine? Or other pieces of technology or, I don't know, anything really?
I've had a dream. You know, I started in my career with the psychological components of the illnesses and the psychological treatments, right?
Yes.
And today, psychiatry completely turned into the biological, you know, to do the same, to make diagnosis and to do treatments. So an integration of the two in one, if possible, has been my dream. You know, and to identify an area where the two can meet together would be to find the point of union between unconscious and conscious, you know.
Yes.
We more or less know where the conscious is, biologically speaking. You know, when you see all these neurotransmitters working and we identify the functions of the brain and so on, especially in the cortex. But we don't know where the biological representation of something conscious becoming unconscious, or vice versa, something unconscious becoming conscious is. We don't know what it is. So I think this century in which we are really gives us the opportunity to find that representation at the biological level.
Yes. What were some of the most important drugs that you used early on in your practice, and how have those changed?
All right. In psychiatry, we initially had, as I told you, the barbiturates, the meprobamates, the barbiturates and meprobamates that was used as tranquilizers, the bromides,
Yes.
and the electroshock treatment and the insulin coma.
Of course, yeah.
But in the late 50s, 1950s, in France, they discovered, by serendipity, the first antipsychotic. They discovered Toracin. They were just looking for another agent that was efficient to anesthetize people in surgery. But they found this medication and noticed that it did a lot of wonder for people who were agitated, you know, and Toracin was discovered that way. And that was the first antipsychotic. Second breakthrough was the discovery of imipramine, the first antidepressant, tricyclic antidepressant. So that was in the late 50s. In the 1960s, they discovered the rest of the tricyclic antidepressants, which was great. You know, we still use them today. And they discovered that lithium was actually a substance that could be used to control bipolar disorder, especially the agitation patients with this disorder. Lithium was discovered many, many centuries ago, but it was only in the 1940s that they discovered some of the anti-manic qualities of the substance.
Yeah.
But it was too toxic and we didn't know why. But as time went along, we learned why it was toxic and how to avoid the toxicity, and that's how it was approved to be used again in 1970. So in the 1970s, we used lithium a lot together with the antidepressants. There were other kinds of antidepressants discovered in the 1970s, and in the 1980s, we came up with a famous group called antidepressants, called SSRI group, which stands for selective serotonin reuptake inhibitors. That's a group of antidepressant medications that could be as effective as the tricyclic without having the toxicity and the bad side effects of the tricyclics. So that was a tremendous breakthrough. Simultaneously, we discovered medicines that were very good for psychosis. They were all initially approved for schizophrenic disorders, but later on we have discovered that they are good for many other uses. Prior to that, we had antipsychotics that again had tremendous side effects that were very useful at the time, but with the discovery of the new antipsychotics that are called atypical antipsychotics, we reach another level of treatment that has been very, very rewarding, very rewarding. Then we are talking about these substances like olanzapine, that is a tremendous antipsychotic, and risperidone, and clozapine, and there are a good number, like 5 of them, that are excellent medications for psychosis today. So today we count with a good armamentarium. And finally, there is a group of anti-epileptic medicines that had been found to be very effective to treat bipolar disorder.
Okay.
So that's the last progress that we have made in psychoactive medications.
All right. Well, I think I'll move on from the science, unless there's anything else you would like to talk about from changes in technology, diseases, or procedure, or drugs. Do you have anything else?
Well, I make emphasis in the switch from the psychological to the biological, that has changed our practices. As I told you, I was psychologically oriented because I did psychoanalysis. I specialize in individual and group psychotherapies. But these techniques have taken kind of second place to the use of the medications that we have today, especially if you consider that managed care, which came into the picture in the late 1980s, is more interested in getting the patient free of symptoms than in solving their psychological problems than in anything else. So the psychotherapies or psychotherapeutic techniques are too expensive for them, although they are very helpful to, especially in the prevention of relapses. They are second place to the use of medications today, which have changed our professional identity and the way we practice psychiatry.
Well, it's good that you mentioned managed care there, because that's what we're going to talk about right now. Definitely.
All right.
Well, first, could you tell me how patients without money received care early in your practice?
Early in my practice, as I mentioned before, the state hospitals were the main resource for treatment, psychiatric treatment for patients who had no money or insurance. There were some clinics that were open in the community for people who were indigent, and that was it. That was it. They went to the priest in their parish, or asking for help, and the priest brought patients to us, and they got treatment like that. But many people went without treatment, especially when they were living in distances and they have no transportation means and all that.
Over the years, how do you think Worcester is compared to other places in terms of providing care for the underserved?
I think Worcester is heaven. You consider, never mind Colombia, South America, because over there, either you live in the big city where there is some services or not. But if you live far away, you don't get any services. That's it. Small towns don't have a psychiatrist. It's only the physician of the little town who does whatever he can. But in Worcester, things have progressed enormously to the point that each area, and I include the most underprivileged areas, has a clinic that is available to them. And they just have to walk a few blocks to the clinic to keep their appointments. And with a public assistance program here, they can get their medications, you know. So practically in Worcester, nobody can really justify the lack of clinical services and treatments and all that. They have to be completely out of reality not to get their mass health, you know, to ensure treatment. So we have clinics all over the place, and those people get attention. And if they don't like the attention in one clinic, sometimes they change, you know. When they come here, even though this is a private office, but I see mass health patients, when they don't like something that I do, they switch to another clinic. Yes. And vice versa, it happens too. So it's clear that people in Worcester have good opportunity to reach out for medical services and psychiatric.
What were some fears and concerns about socialized medicine in the 1950s and the 1960s?
Well, at that time, I was not in this country, so I cannot tell you.
Okay.
I could tell you that after I came to this country and I started becoming acquainted with the two systems, you know, the private and the socialized. Our fear always, when they talk socialization, is a loss of quality and a loss of quantity in services, medical services. Just think of medical services in other countries like Canada, England, and other European countries, Spain. I am familiarized with the systems there. People have to wait for a long, long time to see the specialist. And they don't have the right to choose their doctor. If they don't like their doctor, or they have conflicts with him, tough, you know, with him or her, tough. You know, that's the doctor assigned to you and you have to go, or get out of the system and pay. But the cost is very, very high. So that's the fear that we have, that when you establish the socialized type of medical services or medicine, you lose in quality and you lose in promptness and all that.
What were your feelings on Medicare and Medicaid when they came around? Were you scared? Or?
No, unfortunately, I wasn't.
Okay.
I wasn't. Frankly, I haven't heard many comments about the establishment of these systems. Today, I would say that many people are very, very fortunate to have both, you know, when they cannot have other things, you know, and the elderly, of course. They are fortunate to have them. It could be better, but at least they have the basic, and in some cases more than the basics.
Over the years, how do you think that government's increased involvement in the healthcare and with managed care and all that, how do you think that has affected physicians specifically?
Excuse me, I didn't hear the question.
How has government's increased involvement in healthcare and how has managed care affected physicians?
You see, the tendency of governments in general is to believe that we doctors make too much money. and don't produce enough. And the government tends to improve healthcare by cutting down our fees and by demanding that we work more. You know, that's what managed care did. Managed care is not government intervention, but is supported by the government, where the managed care is. Managed care forces you, like it forced me, to see 4 psychiatric patients in 1 hour. You know, that's incredible. You know, I was going, you know, out of my mind, you know, having the pressure to produce, or I lost my job, and this reality. And how about payment? My salary was reduced greatly, to the point that they say if the patient doesn't keep the appointment, you don't make any money, you know? So government intervention, unfortunately, has been like that in most of the cases. And that's the fear that we have, you know, with doctors at least. Because the doctor is seen as a person that is rich and has an easy life, and he just thinking having cars and houses and this and that. They are kind of being the target of intervention by the government to improve services.
And how has the public's access to healthcare in general been affected by the government?
I would say that somehow the government intervention has not been effective to bring medical services to the people of this country. How do you understand that in this country, with all the resources we have, and there are 42 million people that are uninsured, they don't have insurance, not even the regular insurance that most people have. How do you understand that? You know, I don't. And I don't want to be ahead of you, but that's why I advocate for universal insurance systems. Hopefully one day we'll have it.
Well, before we move on, is there anything else you'd like to talk about from managed care or, you know, HMOs, socialized medicine, any of these topics?
Well, probably you heard so much about this, but managed care has made our life miserable, you know, to be honest. You know, has been our energy that was initially oriented towards improving the quality of our care, our knowledge, the interaction with colleagues, communication with colleagues and members of the treating teams. Today is being spent in filling paperwork. Paperwork is something that is taking half of our lives and our energy, and that sometimes drives us desperate, because managed care officers' main goal seems to be to save money. That's it. Besides, the salaries that managed care company officers receive take away from tremendous amounts of money from money that should be spent in improving the quality of the medical care.
Yeah. Well, could you tell me how doctors' salaries have changed throughout the course of your practice?
Yes. Because of the demands of the managed care services and the lack of flexibility and and the expectations from those companies, we have seen our incomes being reduced tremendously. You know,
How has malpractice insurance changed over the years, and how has its impact on doctors changed as well?
what initially was a completely private industry, we had been forced to develop our own insurance companies because the prices were skyrocketing. At some points it was impossible. Some doctors have had to leave practice because the amount of money they pay. It has not been strictly the case in psychiatry because fortunately in psychiatry we have less lawsuits and but say obstetricians, they have to have a minimum of at least, I understand, between 100 and 150 deliveries a year to be able to cope with the expenses of insurance and overhead. So it has come to the point that we have had to create our own insurance companies, and that's what has happened in Massachusetts. I know of at least 2 or 3 companies that we have developed, and consequently has changed, not completely in our favor, but to a great extent, it has improved that part of our practice.
What are some changes that you've seen in the demographics of the Worcester community as you practice here over the years?
Well, just think of this. When I came here 30 years ago, I was one of a handful of Latin people. You know, today we have in this area around 30,000 Latin population. Besides other cultural and ethnic groups have come to this area too. You know, you have the Cambodians, the Vietnamese. They have the Russians, people from Central America, from different countries, San Salvador, Guatemala. They are come here, and some of them are my patients. So we have had an influx from all over the world practically, and that has made things more interesting. And you know, when you mix cultures, things tend to get better at the end. You know, that's the mixture produces an improvement in the quality. And today we see children from interracial marriages that are very interesting people, and they are contributing. So I think Worcester has become a much more interesting place, and I think it will grow even further. And now we are not seen as something that don't exist in Boston. You know, they are beginning to know where Worcester is, and a medical school has made a tremendous contribution for our city too.
What are some changes that you've seen in women's health over the years? We have about 5 minutes left.
As it has happened in many other areas, the women's health care has improved tremendously. More research has been done with female subjects. Consequently, questions about the difference between the two sexes have been answered more often. And consequently, the care of women's health has been more specific, more specialized, and taken into consideration the differences with the opposite sex. And we understand women's psychology much better now, and we understand what kind of illness we have to pay attention to prevent that they suffer from those illnesses, which results in a better contribution from the female part of our human race. to our industry, to our academic work and research and all that. They have jobs today that probably they couldn't have before because we didn't have the means or the knowledge to treat the health problems that interfere with their productivity.
And of course, many more females are becoming doctors nowadays.
That's true.
Yeah.
Absolutely. More doctors are females.
How do you feel that how do you feel the role of the physician in the Worcester community has changed?
First of all, it has expanded tremendously. I knew all the doctors in town when I came here. And of course, we knew the 30 psychiatrists in town. Today, I don't know most of them. But that means that we have more diversification, the quality of the medical care has improved tremendously. We have had the influence of many universities from all over the country and all over the world, from doctors that come from those universities and settle here and contribute. So it has benefited our community tremendously.
Well, I just have a couple questions left. We have about a minute and a half to go. Could you tell me, with medicine being such a changing field, how have you kept up with the changes in education after you graduated from medical school and throughout your career?
There are many courses, many courses that you can take, many meetings, symposiums, conventions that are offered to you locally, regionally, and all over the country and all over the world, and that they have facilitated. By they I mean the universities, the manufacturers of medications, they facilitate. Now with the computers, I have like 10 or 12 CDs waiting for me to review them, and I make presentations to other doctors, and we exchange ideas, and we go to all kinds of meetings, as I said, so that that's the way we keep up with it. Never mind magazines, and publications that are come here by the hundreds.
And lastly, what advice do you have for younger doctors?
For other doctors?
Yeah, young doctors.
Young doctors. Basically, like your work, enjoy it. Try to find the good part of it. And secondly, remember